Good evening, everyone. Welcome to the classroom series. Today, we have Dr. Prashanth Menon. He is a consultant neuroanesthesia and neurointensive care in Apollo Adlux Hospital in Ernakulam. He is going to present a topic about intracranial pressure monitoring in neurointensive care. Over to you, Dr. Prashanth.
Thank you for that introduction. So I will straight away start with the presentation. So I'll start with a brief introduction. So ICP dynamics in brain injury may offer insights into areas of opportunities in treating brain injuries. The ICP changes reliably reflects the pathological process in the immediate milieu of the injured brain. Monitoring and analyzing ICP may help in treatment decisions which may translate into favorable outcomes. Although not very commonly practiced, ICP monitoring is a key component of multimodality algorithms, which is gaining favor in the recent times. Now let's look at the brief history of ICP monitoring. So in 1842, Francois Megendi brought in the idea of fluid within the brain. And George Burroughs in 1846 postulated that there is a reciprocity of intracranial CSF and blood volumes. Harvey Cushing in 1926 said that this reciprocity of CSF, blood, and of course another component called brain is there in the intact skull. What are the components of intracranial pressure? So broadly speaking, all these components, that is the brain comprises of neurons, glial cells and meninges, then the blood, which comprises of the blood in the arteries, capillaries and venous system, and the fluids, primarily the CSF, and then of course the intracranial and extracranial fluid of the brain exerts this intracranial pressure. Now the fundamental of ICP monitoring is something called as the Monroe-Kelly hypothesis. The cranial compartment is an incompressible fixed volume, and if there is an increase in the volume of one of these components, that is the tissue, blood, or the CSF, until and unless the other component is reduced in volume, the net pressure will rise. So whenever there is an increase in volume of one of the components, the principal buffer is the CSF and to lesser extent the blood volume. Because the brain being more of a solid state and relatively incompressible cannot compensate much. And this compensation is also able to maintain a normal ICP to a reasonable level only when the volume change is less than around 100 to 120 ml. That too, if it's a very old person with a reasonably atrophic brain. So this is a schematic diagram that shows the compensation as the intracranial volume of any of these components increases. So initially there is the venous blood volume which is displaced, then there is the CSF volume. Later on there is compression of the arteries as well, but later on once the brain becomes ischemic and vasoplegia sets in, the arterial components is fatigued and then there is a relative increase or hyperemia. So what are the indications for ICP monitoring? So the primary focus of ICP monitoring has always been traumatic head injuries. However, recently this has been explored in intracerebral hemorrhage, subarachnoid hemorrhage, hydrocephalus, malignant infarctions of any cause, severe cerebral edema, CNS infection, primarily viral encephalitis, and of course in metabolic encephalopathy like Reye syndrome and hepatic encephalopathy. So in traumatic head injury, the Brain Trauma Foundation has recommended, given a class 2 recommendation to ICP monitoring, particularly in severe traumatic brain injury with an abnormal CT scan. And a class 3 evidence for ICP monitoring in a patient with severe injury with initial CT showing no abnormality. But if the patient manages any of these two cardinal signs, that is, when the age is more than 4 or show unilateral or bilateral motor posturing, or if the systolic BP is less than 90 millimeters of mercury after resuscitation. However, as I told you, ICP monitoring has been gaining favor in other diseases as well, like in subarachnoid hemorrhage, particularly when the patient is having a very poor grade SAH and the patient is in coma. And also when you're planning to actually start a triple H therapy, which is the conventional treatment strategy in SAH. And if the patient manifests an early or late hydrocephalus. In other hydrocephalosis also, when you are suspecting a shunt malfunction, or when you are trying to uh, treat the patient with the CSF diversion procedure, an ICP monitoring may be beneficial. There is no good clinical evidence to suggest that there is any benefit of ICP monitoring in spontaneous intracranial hemorrhage. However, the secondary injury following an intracranial hemorrhage, the ICP monitoring may have some value. In normal pressure hydrocephalus, ICP monitoring may be useful in prognostication of the outcomes after a diversion procedure. Similarly, a lumbar catheter is used for the diagnostic and therapeutic response to a therapy in benign intracranial hypertension. And you can use ICP targets in treating Reis syndrome. Indications in other diseases like tumors are not routine. However, it may be used when there is an associated risk of malignant cerebral edema, or there is a risk of hydrocephalus, particularly in posterior fossa surgeries. Any cause for coma or severe cerebral edema, ICP monitoring may have some value, particularly in targeting the therapeutic thresholds. So what are the ICP monitoring techniques? So broadly speaking, you can classify it into invasive techniques, which is the gold standard, and the non-invasive techniques. And these invasive techniques can again be subclassified based on the technological differences that are used. So one technology, and the simplest and the gold standard, is the external ventricular drain connected to a strain gauge pressure monitoring system. The other technology is the microtransducer, where the tip itself has a microtransducer mechanism. So the technology differs slightly depending on the companies. Like you have the fiber optic, pneumatic, and strain gauge techniques. The other way of classifying the ICP monitor is based on the location. This is primarily of historical interest only. Anyway, I just mention it for the sake of the completion. Intraventricular, intraparenchymal, epidural, subdural, subarachnoid. The other way of monitoring ICP is a non-invasive technique. This is actually because the invasive techniques comes with inherent problems of infection, bleeding, and you need a lot of logistics and personnel to actually manage it, particularly when you're using it for long-term continuous monitoring. So the non-invasive methods that are used are transcranial Doppler ultrasonography based on pulsatility index, tympanic membrane displacement, optic nerve sheath diameter via transocular ultrasound, and of course your CT and MRI, pupillometry, NIRS, EEG. Various other techniques have all been used and correlated with the actual ICP. However, the absolute values that are derived through these techniques are actually not very accurate, or they are primarily used as trend monitors and also to look at the response to your treatment. So when you look at the invasive monitor, there are certain considerations. So what type of monitor are we using, and where exactly should we place these sensors? Should it be in the dominant hemisphere, in the ventricle? If in the ventricle, which ventricle? And if it is a generalized or diffuse injury, then where exactly should this be placed? And the validity of the measured value. And there are some desirable characteristics of these monitors. One is the values that are derived should be reliable, and if it is used for long term, it should be stable without much of a drift in the value. It should be simple and easy to place with minimal risk of infection and bleeding, and the measurement should be ideally continuous, and you should also have the potential option of therapeutic drainage of the CSF, and should be relatively inexpensive. Broadly, I think EVD has many of these qualities, but none of these techniques are 100% fitting into the textbook. So this is the diagram showing the microtransducer based monitoring systems. So you have the micro strain gauge or fiber optic and pneumatic sensors. So the relative advantages and disadvantages, I would only stick to the intraventricular and the main monitors that are currently being used, which are used intraparenchymal or using the microtransducer techniques. So as I have told you, that intraventricular catheter is the gold standard because it is relatively easily you can apply it, and it is easy to maintain, and it also allows CSF to be drained, and the drift is relatively less, and all the other techniques are validated based on this gold standard technique. Now we have got some of these fiber optic strain gauge and pneumatic versions of the ICP monitoring, and the relative uh, risk and the zero drift of the value, and the capability of zeroing it in vivo will described in this table. You can see that most of these intraparenchymal monitors will have a zero drift over a period of time. However, they are having reasonable accuracy and have been validated with the gold standard, that is the external ventricular drainage system. But the relative risk of infection and bleeding is lesser when compared to the conventional EVD. So intraventricular catheter is the oldest and simplest, and it is usually put through a burr hole or during the surgery after a craniotomy. So it is a fluid-filled catheter which is placed in the lateral ventricle, and it is connected through a conventional fluid-filled transducer system. So the advantage here is that since you can have a free access to the ventricular system, CSF drainage is possible, and you can also assess the ventricular compliance by looking at the pressure-volume relationship. Can also be used as a portal for injection of injections like antibiotics, and in some cases thrombolytics, and repeated zeroing is possible. The most important disadvantage is it's highly invasive, of bleeding and the risk of infection. And of course, when you pass a catheter in a trauma patient, there's always the risk of injury to the brain parenchyma and hematoma. And sometimes, particularly when the brain is distorted or the ventricle size is small, it is difficult to place the catheter. And sometimes you may need image guidance to place the catheter. So in these cases, it is better to avoid excessive handling, avoid a continuous fluid flush system which we use in other fluid-based catheter transducer systems, and avoid using preservatives in the saline which is used to flush. And the transducer should ideally be zeroed at the level of the external aortic meatus. The other variant is when you place a catheter into the lumbar subarachnoid space. The measure correlates well with the ventricular pressure when there is continuity between the two systems. However, it is not useful when the CSF pathway is blocked, or if the patient is having very high ICP and there is a potential risk of herniation. The other techniques like subarachnoid bolt and all are primarily of historical importance because they are rarely used nowadays. So this is one such technique which is called as the subarachnoid bolt, which is placed screwed by putting a burr hole. And the advantage is that it was relatively easy to place. However, the accuracy, validity, and the potential limitation that it cannot be used for CSF drainage has limited its use. So this shows the image of a subarachnoid bolt. See, when it is in the center image, you can see when it is optimally placed. But most of the times when it's put blindly, it may be placed obliquely, and it may not reliably reflect the true ICP values. So to circumvent this, they brought in other techniques like cup catheters placed in the subarachnoid space, which were easier to insert, and technical errors were reduced. So this is a cup catheter placed in the subarachnoid space. So this is a ribbon-shaped catheter cup which is placed under the skull, just below the dura. Then we have epidural transducers. So these are also placed using a burr hole. You this schematic diagram which is depicting epidural transducer placed on the skull. These are also relatively less invasive because you're not actually entering the brain parenchyma or the ventricular system, so the potential risk of infection is much lesser, and it reasonably correlates with the intraventricular pressure. The disadvantages with the others, as with other systems, we cannot be using it as a port for CSF drainage or injection of drugs, and the accuracy is not, when you're looking at exact thresholds or if you're looking at waveform analysis, I don't think this is the best option to go with. So Gale-Tech system has one of this epidural catheter transducer system. So this is actually a microcatheter based system which is placed epidurally, and this can be used to monitor the ICP. The advantage here is that since there is no fluid coupling, the risk of infection is significantly reduced. And the advantage again is that you can zero it in vivo. Then you have the pneumatic epidural catheter. So most of these systems are of historic. The standard is to directly go for an intraventricular catheter or for the intraparenchymal catheters. This is a new technology where a fiber optic probe is placed intraparenchymally, and it can be used in other areas also, like epidural and subdural also. But the best results are when you use it in the So this is based on there's a flat reflecting disc at the tip with two fiber optic pathways and a monitoring disc, and this disc is connected to the monitor. So you can see here, this is the disc, and the two fiber optic light are passed, and it actually reflects back from the surface, and the change in the reflectance actually correlates well with the pressure. The advantage of the system is that it is reliable, and can be used in multiple locations, that is intraventricular, subdural, epidural, or intraparenchymal. The disadvantage is that zeroing is not possible in vivo, and there's a risk of potential breakage of the optical bundle, and the manufacturer recommended monitor can already be used, so that can add to the cost of the system. So the Camino Laboratories has brought in the fiber optic catheters for ICP monitoring. Then I'll just briefly give an overview of the non-invasive techniques. So okay, transcranial Doppler. So this is a relatively non-invasive technique which can be used to assess the ICP. So this is based on pulsatility index. So we actually calculate the pulsatility index as the, and you use a formula to derive the approximate ICP. However, the values that are derived from this formula, this 10.93 into PA minus 1.28, is not accurate, but it has been validated in several studies. The limitations is it's primarily a qualitative assessment, and if the patient has vasospasm as in subarachnoid hemorrhage, uh, so, um, it is a qualitative measurement, and if there's a vasospasm as in subarachnoid hemorrhage, the values may not be right, and the quality of signal in some patients may not be very good, particularly when there's a thick bone. The other technique that is used routinely is the optic nerve sheath diameter. So, as we all know, that optic nerve sheath may be considered as the projection of the forebrain, and it is surrounded by a dural sheath. So ICP is reliably reflected with this continuous dural sheath in the optic nerve sheath. So a 7.5 megahertz probe is and it is assessed over a closed eyelid. So the nerve sheath is usually assessed 3 millimeter behind the globe, and the value of more than 5 is considered as significant. So this is the diagram showing the assessment. So a value of more than 5 mm is considered as abnormal. The other non-invasive technique that is used is called pupillometry. So pupillary constriction velocity is qualitatively assessed. So pupillary response to light reflex is inversely related to the ICP. There are systems which are infrared based, which automatically tracks the movement of the pupil and gives a pupillary score that is called as NPA, neurological pupil index, which is a scalar value which is derived from the size, percent constriction latency, and the dilatation velocity, and the value somewhere between 0 to 5 is given. An NPA value of less than 3 is a predictor of increased ICP. And the advantage here is that the pupillary abnormality starts 16 hours prior to the actual peaking of the ICP. The other technique that is used is tympanic membrane displacement. So this is based on the premise that the cochlear aqueduct, there's perilymph, and whenever there's a movement, raised ICP, there's an inward movement of the tympanic membrane, and this volume displacement correlates well with the ICP. And this has been used in some centers, but again, there are some limitations. That is because you have to place the probe within the external auditory canal, which is not very comfortable, and the value that is derived, the absolute value also is not does not correlate well with the actual ICP. So it is not useful when there is an absent stapedial reflex, or when there is a middle ear dysfunction and brainstem dysfunction, and when there is no inner ear dysfunction as a cochlear damage. Now we'll come to the core issues here. That is, how do you interpret this ICP? So there are two ways of looking at it. You can look at the numerical value of the ICP, or you can do a waveform analysis. Normal ICP value. There's no universal or arbitrary value that can be said to be normal, because this ICP itself changes with age, with posture, and with the clinical condition of the patient. So the 7 to 15 millimeters of mercury in the horizontal position, and it could go as low as minus 10 millimeters in the vertical position. So in adults, value of 10 to 15 millimeters of mercury is taken as normal, and in children it is somewhere between 3 to 7 millimeters. 1.5 to 6 millimeters. Some of the arbitrary thresholds that have been described are in hydrocephalus. A 15 millimeters mercury value is taken as a cutoff. Similarly, the Brain Trauma Foundation describes a threshold of 22. It was somewhere between 20. Recommendations say that it is somewhere around 22 millimeters of mercury where the therapy has to be aggressively instituted. And most studies describe a value somewhere between 15 to 25 to be the danger level. But the problem with this ICP threshold is that there is no level 1 evidence to support any particular threshold. However, there is level 2 evidence to say that treatment may be initiated when the ICP level is above 22 in brain trauma. And of course, you can use ICP with other clinical findings and CT findings to actually come to a conclusion. Similarly, there are cerebral perfusion pressure thresholds which have been recommended by the Brain Trauma Foundation, and the range of the cerebral perfusion pressure is somewhere between 50 to 70 millimeters of mercury. And you may need to actually additionally monitor the cerebral blood flow, oxygenation, and metabolism to come to a unitary alignment of all these values. The other way of analyzing the ICP is looking at the normal waveform. Now, one thing that we have to understand is that the ICP wave itself is a composite wave with multiple waves forming the which with multiple frequencies and power amplitude. However, when we look at waveforms, we can actually divide it into 3 or 4 major waves. That mainly caused by the arterial pulsation in the large vessels within the brain. So they produce an oscillation in the volume of the ventricular system. So this vascular wave can be divided into 3 parts. The first wave, or P1, is a percussion wave. It represents the systolic arterial pulsation. The second wave, or P2, is of most significance to us, and it represents the intracranial complaints. The third wave, or P3 wave, is the dicrotic wave, which represents the venous pulsation. When you look at the wave, you see that the P1 wave is the largest wave in the configuration. So this is a diagram which shows a normal ICP wave in the purple color and an abnormal ICP waveform where the P2 has actually overshooted beyond the P1, and it looks like a head and shoulder pattern, so which shows a poor intracranial compliance. Similarly, there can be variations in the intracranial pressures by virtue of the respiratory movement and changes in the intrathoracic volume. So this really corroborates the central venous pressure changes with changes in the intrathoracic volume, and this is very prominent when the patient is on ventilator. So the single wave analysis can be interpreted in the following way. So for example, if there's a mass lesion, there is an increase in amplitude of the P2 wave signifying loss of compliance. When there's an increase in the CSF volume, there is a decreased amplitude or increase in amplitude of the whole of the wave, or change in the mean ICP value. When there's arterial hypertension, there's primarily an increase in the P1 amplitude. When there's an increase in the cerebral blood volume, there's an increase in the P2 amplitude. Very massive, significant rise in the ICP leads to what is known as a rounding of the, that is all the 3 waves fused together to form a rounded wave. So you can see on the right hand corner, there's a rounding of the ICP waveform. The other way of looking at the ICP is looking at the mean ICP trends. So you have got 4 charts here. So in the first chart, you can see there is a low and stable intracranial pressure, which is the normal pattern. The other thing is, in the initial stages, there may be a stable and elevated pressure. The mean ICP remains elevated, but it is stable. Then the third waveform, there's intermittent spikes, which are elevations which comes back to the baseline, or you could have plateau wave. There's sustained elevation for a long time, which comes back to the baseline. And of course, the correlation with other waveforms, that is arterial waves, the flow velocity of the transcranial Doppler, this can all be used to interpret the ICP, but this is not routinely used. The third way of analyzing the waveform is looking at the types of waves. So apart from these waves which I have already, arterial and respiratory pulsation. Some of these waves were classified as type 1 waves and type 2 waves by Jani in 1950s. So this is primarily based on the frequencies and amplitudes. The other commonly used pattern that is used in clinical practice is the Lundberg waves. So he classified the waves into three types, A, B, and C. And then there's another third way of classifying, that is the slow waves. That is again subclassified into ultra B, B, and infra B waves, depending on the frequency. And they're very, very slow waves. And I'll come into the slow wave based interpretation later. Now, the Lundberg wave, the most significant of that, the Lundberg wave is the A wave or the plateau wave, which indicates an imminent herniation or very severe rise in the ICP. So these are very large waves of 50 to 80 millimeters in amplitude, which are lasting for about 2 to 20 minutes. And then suddenly they fall back to the baseline. So they are always pathological and they reflect extreme compromise in the compliance of the brain. And they may, if left untreated, lead to herniation and brainstem dysfunction. The other abnormal wave that you see is the Lundberg B wave. So these are rhythmic oscillations which are smaller in amplitude and they occur every 1 to 2 minutes. The amplitude is somewhere between 20 to 30 millimeters of mercury. And this also shows an a poor compliance of the intracranial waveform, and it is always associated with the change to respiration. And it depicts the cerebrovascular tone and the cerebral blood volume. The third wave is called the Lundberg C wave, which are of doubtful pathological significance. And it may just represent the normal changes in the arterial tone, which you see with the Trop-Ring-Mayer type of variation. That is the arterial blood pressure variation with baroreceptor and chemoreceptor based mechanisms. So this diagram depicts the three waves. Lundberg A on the left, extreme left, which is the sustained elevation, very high amplitude, lasts for a longer time. And then the B wave. So here A and B are may be considered as the similar waves with difference in severity, with A wave being more severe. Now, as I told you, there is something called slow waves. So slow waves are pressure oscillations which are very, very low in frequency. That is somewhere between 0.05 to 0.005 hertz. It may be seen in pathological as well as the physiological purposes. So when you do a waveform Fourier analysis, you see that when you look at grossly at the oscillation, you may not be able to identify the different frequencies. But when you actually break these waves, you will see that the extreme left you have the very slow waves, which are very small in amplitude and very slow. The frequency is also very less. This is followed by the respiratory wave, which has an amplitude of around 3 hertz. And they are also not very fast. So they're slightly faster than the slow waves, but they also occur less frequently. Then you have our pulse wave or the arterial waves, which are smaller in amplitude, but they occur more frequently. Now, a normal ICP monitor may not detect these slow waves, so you need special filters with low printer resolution to detect these waves. So you may need a computerized recorder and digital filter to actually look at these waves. So in this diagram, you can see that without a filter, you may not actually appreciate this B waves at all. So when you use the filter in the subsequent images, you can actually look at the B wave morphology. And so what's the origin of these slow waves is that it actually represents the normal intracranial pressure dynamics, and they are present even in physiological conditions. However, in pathology, they are amplified. So this is again a schematic diagram. So a physiological slow wave, and on the right side you have a pathological slow wave. The same physiological slow waves are amplified in the pathological conditions, and there are two theories to actually explain it. First theory is that called the catecholamine theory. That is, when there is ischemia to the upper brainstem, there's a pushing response and increase in sympathetic activity, and there's an alteration in the vascular tone leading to the amplification of the slow waves. The other theory is called the neuropacemaker theory, where there's an increase in parasympathetic activity due to basal forebrain and brainstem and cingulate cortex involvement, and there's again an alteration in the vascular tone. What are the uses of these slow waves? Primarily, it indicates intracranial compliance. A decrease in compliance, there is an increase in the amplitude of the slow waves, and more than the absolute value, the trends are more useful. And it may be used to correlate with other variables like cerebral perfusion pressure, ICP, and SGVO2 in a multimodality monitoring scenario. And in prognostication in certain conditions like normal pressure hydrocephalus, where an increase in slow waves during sleep indicates a better response to a diversion procedure. Similarly, in hydrocephalus, post-procedure, if there's a decrease in the B wave amplitude, it indicates a good prognosis. And it may also be used in various researches where you're actually correlating it with static and dynamic autoregulation. Now, again, there's another assessing the ICP, that is by looking at the independent individual factor analysis. So most commonly used factor analysis here is the ventricular compliance or the pressure volume relationship. And the other thing is the vascular reactivity to the changes in ICP. Then there's another way where you look at the combined analysis, where you look at two variables in a time or frequency domain and come to a conclusion. So in the compensatory reserve, what we commonly use is you look at the ventricular compliance. So the most commonly used measure here is the pressure volume index or pressure volume curve. And then you have the correlation coefficient between the amplitude and the ICP, mean ICP. And there are other techniques called power spectrum analysis of the pulse waveform, pulse transmission between the arterial pressure and the ICP, the ratio of the respiratory wave to the pulse amplitude of the ICP, and the power of slow waves of the ICP. Now, this is the normal pressure volume compliance curve. So you can see here that initially when the volume in the intracranial cavity increases, the pressure is changing very negligibly or it does not change at all. But as the decompensation occurs, there is an exponential rise in the pressure as the volume changes. And beyond a certain stage, it becomes very steep. As the equation is exponential, this relation can be written in another way. When you use logarithmic values, the relationship can be made more linear. So the pressure volume index is again derived from this kind of logarithmic relationship between pressure and volume. So pressure volume index can be defined as the volume of fluid injected or withdrawn into the ventricular system that causes a 10-fold change in ICP. Now let's have a fair idea of this, that in a normal adult, this value is somewhere between 25 ml, in an infant it's somewhere around 8 ml. That is, if you inject 8 ml of saline into the ventricular system, there is a 10-fold increase in the ICP. This is calculated from the formula as the pressure volume index is equal to delta V divided by log of PF by PO. So as I told you, this logarithmic relationship makes the relationship more linear. So you can see the log of change in pressure with volume is a linear relationship. So the calculation becomes easier. That is the basic advantage here. The other compensatory reserve that you can derive from ICP monitoring is the relationship between the amplitude of the arterial waveform and the mean ICP. So this is a moving correlation coefficient of 40 samples, which is taken in time frame of every 6 to 10 seconds. And it is analyzed continuously. So this waveform is a moving average, average which keeps changing with every 6 to 10 seconds of data recording. So what this actually depicts is, when you look at the relationship between the arterial wave amplitude and the mean ICP relationship, when there's a good compensatory reserve, the correlation coefficient is 0. That is, there's no change. They are mutually exclusive. When there is a fall in the compensatory mechanisms, the relationship becomes almost 1. That is, when there's a change in the mean ICP, there's a change in the amplitude of the arterial wave of the ICP. And then towards the end, when the compensation is totally exhausted, the relationship becomes negative. This is primarily because there's compression of the vessel and no flow state is reached. So this is again a schematic depiction where on the left side you have the variable of the arterial pulse waveform amplitude of the ICP, and on the right side you have the mean ICP amplitude. So you see that when there's good compensation, there are absolutely no uh, correlation of 0, and when the compensation is inadequate, you have a correlation of +1, and when it is exhausted, again it goes negative. The other techniques used to assess this compensatory reserve is a power spectrum analysis of the pulse waveform, and of course the pulse transmission between the arterial blood pressure and the ICP. These are not routinely used because of the complexity of the monitoring devices itself, and also the multiple variables which decides both the ICP and the arterial blood pressure. So this is not routinely used. It's just for academic purpose. The other thing which can be visually assessed is the ratio of the respiratory wave to pulse amplitude of the ICP. So when there's a good compliance, there's a good modulation of the pulse wave by the respiratory cycle. As the compliance decreases, the variability due to the respiration changes. So this cannot be exactly quantified by eyeballing, but you can roughly see that the baseline undulations are lesser when the intracranial compliance is lost. And as I've already discussed, there's a power of the slow wave which can be used to assess the ICP reserve. So this is the summary of the compensatory reserve that can be assessed by ICP monitoring. There is the pressure volume index, the RAP, the pulse transmission between arterial pressure and ICP, the ratio of the respiratory wave to the amplitude of ICP, and the power spectrum analysis of ICP pulse waveform, and the power of slow waves of ICP. The other way of looking at it is the cerebrovascular pressure reactivity. That is, you are correlating ICP with the cerebral perfusion pressure. So this is actually done by assessment of the cerebrovascular reaction in response to the ICP. So this is again measured as a correlation coefficient of 40 samples, and it is again continuously, it's a moving average of the correlation coefficient, and it correlates, the values actually correlates well, and it is a useful tool in making clinical decisions and also to predict outcomes. So here you can see a graph on the right side where the pressure reactivity index is plotted against the CPP, and you can see that you can actually see a U-shaped curve where you can actually target the optimal cerebral perfusion pressure. So the optimal cerebral perfusion pressure would be somewhere between 0.7 to 1.3. The correlation coefficient is somewhere between 0.7 to 1.3. So in conclusion, there is still ambiguity on the role of ICP monitoring and the ICP guided therapy because we don't have very strong evidences to actually support them. However, ICP monitoring is an important guide in the critically ill patients and may be used in concordance with other management protocols. So understanding the basics of the monitoring techniques and the principles is a prerequisite for proper implementation of ICP monitoring protocols. Thank you.
Thank you, Prashant. Thank you for such a wonderful and very thorough discussion of ICP monitoring. I just have one question. Usually, we do ICP monitoring as a part of tear therapy to decide whether the patient needs to undergo a decompressive craniectomy. So, is there a role of ICP monitoring even after the decompressive craniectomy has been done?
Yeah, maybe. See, actually, the conventional thinking is that looking at any arbitrary value of ICP to decide on treatment plans are useless because most of these cerebral damage have known to occur at thresholds or pressures below the threshold. However, there's another concept of compartmentalization of ICP. That is, if there's an injury to one side of the brain, and the pressure on both sides may not be equal, and there may be gradients between the two compartments. So in this scenario, actually ICP monitoring is very essential even after a decompressive craniectomy. But the grossly speaking, when you look at ICP is actually the pressure difference. When you take out the atmospheric pressure out of the equation, the ICP, relative to the atmosphere is zero. Because you've done the tier 3 therapy of decompressive craniectomy.
Exactly.
Yeah, but then if you have an intraparenchymal probe, you can look at the parenchymal pressure, compartmental pressure, and it may definitely, when you're using with a multimodality like say PVRO2 and other cerebral blood flow monitors, it may help in treatment decisions.
Correct. So yeah, like so many times the patient can still have a raised ICP despite DC, maybe because it was not properly done. Only a small portion of the bone was removed. So yes, we can definitely monitor even after the decompressive craniectomy. Thank you, Prashant. Thank you so much for this wonderful session. We look forward to further presentations with you again. Thank you, Prashant.